One second. We're gonna. It's very sunny today, isn't it?
Lovely, yeah.
Yeah. Okay, you can go ahead now. Thank you very much for the start.
Okay, as part of the annual Congress, we have an ultrasound and chronic pain workshop, and I'm going to take a section about ultrasound and its use in terms of interventional pain management for back pain. So my name is Dominic Harmon. I have a big experience in terms of the use of ultrasound. I would normally do approximately 50 ultrasound guided procedures weekly. I published a lot in terms of literature, but also here's a textbook. Perioperative diagnostic interventional ultrasound. It's got big chapters on pain medicine as well. This book is in around 20 different languages. So that shows you a bit of my background experience. Okay, a very important thing that I find, and somebody working a long time in chronic pain, that pain diagnosis is absolutely crucial. So I'm going to say a few points about that, and then I'm going to show you how ultrasound plays into that. First of all, in terms of diagnosis, common things are common. So like, for example, if you have neck pain, it's quite common. You could have shoulder pain. If you have back pain, it's quite common. Hip pain, same in terms of age perspective. So older patients, it's quite common. You could have hip pain. Now, another thing that's virtually the norm is that there's multi-sources to pain. That's the norm in terms of patients attending a pain clinic. So any patient who has back pain, you actually have to automatically look for the hip pain as well. Now, understanding the mechanisms of pain generation is important, and how having one problem can lead to another problem. And now a patient has two generators of pain. And this is very relevant in terms of the treatment of pain, not only in terms of intervention, but also in terms of, for example, explaining pain and treatments to patients. In terms of the diagnostic aspect of things, the most important are the skills and training of the doctor. And we need to be aware of the limitation benefits of the patient report, physical examination, imaging, and all of these are part of the diagnostic circle in terms of to do our best to get the most correct diagnosis. I'm going to mention here about the relationship between sonography and clinical examination. So the clinical examination, very important in terms of diagnosis intervention, and the sonography can play a big role in this, which I will show you. And that links in then to, again, diagnosis and intervention. Ultrasound is an excellent tool, and it's a tool just like what X-ray is, and I hope I'll show you some of the tools that it's benefit in terms of back pain. It improves functional anatomy knowledge. As you learn more, you can progress on with the use of ultrasound. It improves examination skills, and it improves intervention skills. In the diagnosis, I'm going to mention possibly what you haven't heard before is sonopalpation. And also I'm going to mention, it's just a phenomenon that's just beginning, and I think it's going to get greater importance, that there's a greater push for ultrasound diagnostic skills of the non-radiologist for common conditions. So i.e. the pain specialist who uses ultrasound would improve their skills, for example, in diagnosing gluteal tendinopathy, a condition that's very common, affecting 1/3 of women over the age of 40. Okay, so some basic things in terms of use of ultrasound and pain, chronic back pain. Typically, patient is prone, pillow under the abdomen, use a low frequency transducer. You're going to use the technique of sonopalpation, which we'll come to again. I'm going to make a point about injection techniques, okay? And you'll be using both in-plane and out-of-plane techniques. Here are the transducers, linear transducer and a low frequency curvilinear transducer. And most commonly, you're going to use the low frequency transducer because you're working at depth quite often. Some basic things about setup. The screen is typically opposite to the operator. Typically, you hold the transducer in the non-dominant hand, and you use the dominant hand then to hold the needle. Now, there is a good skill in terms of becoming ambidextrous. Patient is central, and again, you're looking straight across. You're seeing the needle entry site, and you're seeing the patient, and you're seeing the screen all at one time. And the syringe is attached to the needle and ready to go in terms of you're going to inject when you reach your target site. Now, so we're moving on to the back pain, and here are some of the procedures that I'm going to cover. Lumbar medial branch, periarticular facet joint injection, sacroiliac injection, gluteal and caudal epidural. Now there's your basic anatomy of your lumbar vertebra. You've got your spinous process, you've got your facet joints, and you've obviously got your vertebral body, which is not really relevant to the procedures we're doing. Okay, the bony landmarks, they're easily identified. You see a hyperechoic line. So it's a bright white line is what you see. The spinous process, transverse process, facet joints. Now, of course, you're going to see the paraspinal muscles, lumbar paraspinal muscles. The epidural space is hypoechoic, so it's dark. It doesn't reflect. Now, here's an example here's a patient lying prone. That's myself holding a transducer, and there's the image on the screen, the ultrasound machine, and actually it is looking at the lumbar spine area. So Sauna palpation, and I've mentioned in terms of diagnosis, patient report is obviously relevant, physical examination. These are helpful, but now very important to follow an algorithm approach. So you'd have to know the conditions that you're looking for. You have to know what is common and what goes with one condition goes with another. So again, in terms of examining the patient, you're looking around the common sources of pain. And again, we're going to use ultrasound to help us. Of course, actually, outcome of injection also helps us with diagnosis. Now, this is the concept of sonopalpation, and I'm going to play you a video clip. So that's sonopalpation, and you see the algorithmic approach. The patient is helping us, giving us a rough indication, and then we're going through the sources of pain. And then we even check around, we do further. So in this patient is around the sacroiliac joint, but we still went to check the gluteal area. And then these are conditions that commonly coexist. So there's the use of sonopalpation. Now we look at this, the lumbar facet joint, very common procedure. Here's some diagrammatic, the nerve supply to the lumbar facet, what they call the medial branches. Okay, now an important thing in terms of the medial branches, so not only do they innervate the joint, but they actually innervate the paraspinal muscles. And it's a very common thing that you have muscle spasm going with back pain. So you have this concept of either doing facet joint injection or whether you're doing medial branch. And the medial branch, okay, it innervates the joints, but also innervates the paraspinal muscles. So quite commonly, I actually would nearly do both type of injections. Maybe more elderly patients, more aiming towards the joint injection, and more in younger patients aiming towards the medial branch. Okay, and we'll mention things about both of these. So here's an ultrasound image. It's a longitudinal scan, okay? Now, I wouldn't often use this type of, but what I show approach in terms of injections, but what you're seeing here is the skin from the top and down here. Now you can see bone, and in fact, you can see the facet joints here. Now, I would never use this type. You can use this type of scan to maybe tell the depth, the level you're at from L5. You know, I most commonly would look down here, the sacroiliac joint, L5, S1, and count upwards that way. But this is another way of counting upwards. I don't really, in terms of joint injection, I mostly follow the technique of periarticular rather than intraarticular. I really don't see the benefit. Now, maybe a benefit might be if there was a cyst of the facet joint, that maybe you might go intra-articular. So, but I might say that in terms of an intra-articular approach, that maybe this might be a better approach, this longitudinal approach like this, that you may be able to drop your needle into the joint from this approach, more so than coming from the side. Okay, now the ultrasound probe has been moved more laterally, and obviously we're going deeper from the skin, and these are the transverse processes. Okay, but we normally when we're doing procedures, we go at this kind of transverse approach like so. And we're seeing here your spinous process here, and your transverse, beg your pardon, your paraspinal muscles, rectus spinae, quadratus lumborum, and then you're down to the lamina, and then you'll be looking at things at the facet joint and the transverse process. Now, to show you a tiny bit more detail here, so here's the skeleton, and over here's an ultrasound image. And on the skeleton, you see the facet joint. Now, here's one of the tricks of the trade to point out to you, that the facet joint is virtually gone by the time you actually see the transverse process. Okay, so if you look at this image over here, this is the spinous process, this is the lamina, you can talk about the superior articular process. Now, this line down here, even though on this I've actually labeled this is not the transverse process. This, in fact, is the iliolumbar ligament. And now, the reason is that this is where we are with this image over here. And actually, you will see a white line. It'll be called the iliolumbar ligament. But normally, you can see deep to it. You can see other tissues deep to it, as you actually can do here. So, as you scan down here, the facet joint is virtually gone, and then you see the transverse process. And you see that from the diagram here. Here's a bit of an ultrasound video here. We'll show you some of the details. So up here, for example, is the spinous process. We're scanning laterally here the paraspinal muscles. And now we're going up and down. This, for example, here is the facet joint. And over here, this is not the transverse process. This is the iliolumbar ligament. Because at the top of the facet joint, you do not see the transverse process. There's a facet joint. And we're doing a transverse approach, looking at it here. And you'd have to scan down before you see the transverse process. This is all the facet joint. Paraspinal muscles, skin. And you can actually see the likes of tissues going on down here. So that's all the iliolumbar ligament. And you'd have to bring the transducer downwards, which is happening here. The facet joint is virtually gone. And then the transverse process will appear. Okay. Now here's an image, and it's showing you, for example, transverse process here, and the needles come from laterally. It's one of the earlier papers on it, and you're down to the transverse process here. Here's an image here, and again, here's the facet joint. So again, you have to question, you see very little of the facet joint when you truly see the transverse process. So in fact, I actually would say this is the iliolumbar ligament. Now, here's with the needle in place, spinous process. This is the lamina, this is the transverse process. And of course, the needle is going to stop here. You're going to feel it in terms of hitting bone, okay? And you can do all your stimulation in terms of before rhizotomy technique. Now, again, in the earlier papers, here they are, for example, and they're doing it at each level, okay? So I would show you now, this is a little bit outdated. And over here, here's the skeleton. And again, you'll have your facet joints, and over here, your transverse processes. Here's an image of myself, and really what it's showing really is from one needle entry point, you're going to reach several levels. Okay, so on this side, if you're going to do bilateral lumbar medial branch blocks or facet joints, from one level on this side, you'll hit all the levels. So it's one needle entry point. And when you go over to the other side, you now switch to the short axis approach. So this is the short axis approach, and again, you will hit several levels. Okay, and of course, with practice and experience, you can do this, and you can do it very fast. Sacroiliac joint. Okay, I must say, what I'm going to say about the sacroiliac joint, there's an image here, skeleton, and here's all the attachments. And that's a crucial thing to know about. I think the most common source of pain from sacroiliac joint is from the attachments to the sacroiliac joint, okay? From either the ligaments or the muscles. And again, you can have coexisting between the sacroiliac joint and, let's say, lumbar facet joints, okay? But I'm pointing out here all the attachments. Now, here's a skeleton. Here is an image here. Now, I've written several papers in terms of ultrasound for sacroiliac joint, but here's an image here, and it shows a needle coming from medial. And in fact, I'd have to say, if you're doing an interarticular joint, I disagree. You actually can't do it that way. It has to be more out of plane. And I'll show you now further. So again, we're back to the skeleton, and we'll show you a bit more detailed images here. Now, if we go up to this one here at the top, this represents this line across here. This is the sacrum, this is the ilium, okay? And you'd have to come down further before you're getting towards the sacroiliac joints. This is the sacroiliac joint here, okay? There's loads of connective tissues and attachments, muscles are going on here around the medial aspect of the sacroiliac joint. On this side, high up, you have a thing called the iliolumbar ligament. So it's from L5 up to the ilium, okay? And that's going to be the epidural space, the bird's beak, which I will go through later. Now, here's the secret to the sacroiliac joint. Here's the skeleton, here's the ultrasound image, and this is what I call the mountain. So you see the mountain, which is the ilium, and over here is the sacrum. And if you scan up and down here, you'll see the mountain disappear, and the joint here will appear. So now, actually, here's the joint. You scan downwards, the mountain disappears, and this kind of hole essentially appears, which is the sacroiliac joint. And depending at the top and bottom of the sacroiliac joint. The true sacroiliac joint at the bottom is going to be opposite S2. And you can see a bit of the joint up here opposite S1, but opposite S2. So very close by, you'll have the sacral foramina. Now, I won't be covering that in this talk, but it's actually very helpful to be able to do ultrasound-guided sacral foramina injections. So out of plane to get the needle to pop in truly into the joint. And so here's the example. Here's the sacral crest. Here is the foramina, and here's the sacroiliac joint. So for me, out of plane, the needle pops into the joint. And in reality, I think you have to use Doppler and you will see flow within the joint. Now, I virtually, with all sacroiliac joint injections, will do the sacroiliac joint, but I virtually always actually take the needle out and aim more immediately and inject some of the attachments to the joint at the same time. So here's an example whereby coming from medially, and so again, I have to disagree with that in terms of truly doing a sacroiliac joint, and we've done studies in terms of Doppler flow and confirming it with X-ray. So again, you examine the patient, where is the pain? If the pain is more up towards the top of the joint, again, it's more related to the attachments, and lower down the true joint. Okay. And again, definitely out of plane for the lower aspect of the joint. Use Doppler for interarticular. You inject very small volumes when you're interarticular. You can go larger volumes when you go in the medial aspect of the joint. Gluteal, very relevant. Relevant too because even you can get a hip pain. I linked hip pain with back pain, and the hip can represent as pain in the gluteal area. There are others causes of gluteal pain, and I'll mention one or two, probably the most common ones. So here's an image. Here's the ilium. The bone, here's the low frequency transducer, and over here is the image, skin, and here's the hyperechoic line of the ilium, the bone. And you're going to bring this transducer down. As a transducer down, now you're going into the static foramen, and here, for example, you're going to see a break in the bone. Okay, so that's what you're looking for. And a big one is the piriformis muscle here, and this is medial, this is lateral. And of course, also you can get the patient to rotate their leg, and you'll see this muscle move. Now, the most common cause of pain around this area would be gluteal tendinopathy. So as I would have said, 1 in 3 in terms of females over 40. There's your piriformis muscle. It can be a source of pain. I don't think it's that common, but it can be. And what's much more common is the greater trochanter. This is the bone here, and here are the tendons, and you'd have bursa in between. This is a skin, subcutaneous tissue. And this is showing you the different tendons with the trochanteric bursae. Right, caudal epidural, very easy to do with ultrasound, and it travels up around to L2 level, well described. Typically, obviously, this is the pattern in terms of using X-ray with contrast spread. What you're showing here now, and here's the skeleton, and you can actually practice with the skeleton underwater to practice this type of anatomy and practice even seeing the needle. So here's like a transverse approach. The transducer is transverse across, and you're seeing the sacral cornea here, sacral cornea, skin up at the top here, sacroiliac ligament, and here's bone. Now over on this image, I call it the bird's beak, sacroiliac ligament. This is caudad, this is cephalad, and here is the epidural space, the caudal space. Now again, this is a transverse image. Most commonly, you'll be doing the longitudinal image. But if you had any difficulty, and usually if patients are too thin is the problem, actually patient obesity is not the problem at all. It actually makes it easier. But the patients who are very thin, you'd have to use a high frequency linear transducer. And you'd be going longitudinal. Sometimes you'd have to go transverse like this, but vast majority you do a longitudinal approach. So here's a transverse image, sacral hiatus, sacral cornea either side, and the bone here, the sacrum, sacroiliac ligament. So the bird's beak, here's the bird's beak, the sacrum, the sacroiliac ligament, the skin, and you're going to pass the needle into here. Here's the needle. Usually I'd be using a hypodermic needle. It's very straightforward. It goes like an arrow, dead on straight. No bend in the needle, and with the syringe directly attached to the needle, and the operator is doing the injection. And you use Doppler flow to see the flow. And here's an example of the Doppler flow here and flow here. And then you're going to do your injectate. So the advantages of ultrasound in pain medicine. So I've covered, again, just briefly to go back over, I've covered ultrasound for back pain. And I've talked about, for example, Sauna palpation, which may have been a new thing to you. And I went through some of the real nuggets of knowledge regarding the lumbar facet joint. I went through some of the nuggets in terms of the sacroiliac joint, and we mentioned then in terms of gluteal, greater trochanteric tendinopathy or bursitis is the big common one, and then I mentioned caudal epidural. Okay, and we've gone through Sauna palpation. Now, some of the advantages of ultrasound, no radiation, and this is definitely relevant with like repeat procedures for patients. Patients who are, I've seen patients who are pregnant. Obviously, this is more an obstetric setting, and whether if they, if you're going to do procedures for pain in that regard, and of course, staff, both yourself and your colleagues, in terms of working in the environment. So there's an advantage in terms of no radiation. It's potentially, obviously, of course, more readily available, and it's more portable. Okay, you can leave the intervention suite much easier. Definitely less expensive. There's a fair cost. I've seen what the cost was in terms of my own institution, and we were talking about €1,200 for a session in terms of the radiographer being with the pain specialist to do a pain list. So there's big savings over a year in terms of with the use of ultrasound. Now, with ultrasound, you most certainly see a lot more anatomy than you can with X-ray. You're seeing the nerves, you're seeing the vessels, which this definitely adds to safety. You learn to see the pathology. Of course, you're going to be using your Sauna palpation, as I mentioned. You're going to see the spread of the local anesthetic. Okay, it's all real time. You're not using a contrast agent. And of course, it's probably a better learning tool as you learn more. Like, for example, let's say you're learning about back pain. You're adding to your anatomical knowledge using the ultrasound on a repeated basis. And you go forward in that manner as you know more about conditions and more about the procedures that can be used for the condition. Sometimes the X-ray can be more kind of a static learning tool. I haven't mentioned much of this patient positions. So definitely, I mean, I would do ultrasound guided procedures, patients standing up, patients leaning over a screening table, patients in their wheelchairs, okay? There are no studies about it, but I see it in terms of my colleagues, in terms of staff acceptance, doing long lists, interventional lists. It's much easier with the ultrasound. You're not wearing heavy leads. Better diagnostic, I would definitely say so. I mentioned about actually obesity is not a problem, especially if you're skilled. And it's also with the X-ray, actually, the older the patient, the more osteophytes you get, for example, and actually becomes more difficult using X-ray in older people. And again, you're back down to this multi-source of pain. Safety, I suppose definitely you're talking about the radiation thing there. You're also talking about the likes of intravascular injection. But again, at the end of the day, it's a tool. So it has all these benefits, but you'd have to have the skill and training to provide these benefits of the use of ultrasound in pain medicine. So we're back to this diagram whereby the sonography, ultrasound, helps with our clinical examination. And that's going to help with our diagnosis, which is absolutely crucial. It's also going to help in terms of with the intervention. And I think it also, as a tool, leads to improved functional anatomy. It leads to improved examination skills and improved intervention skills. So that's covering my topic about the use of ultrasound in back pain and in back pain interventions. So subsequently, in the next section, we can cover questions. Thank you.